Welcome. Today we're diving into a rare and fascinating heart condition called congenitally corrected transposition of the great arteries, or CTGA. This complex condition, present from birth, challenges the heart's normal plumbing, leading to a unique set of circumstances we'll explore together. The precise causes of CTGA are still not fully understood. However, it is thought to arise from an error during the early stages of fetal heart development, specifically between the 3rd and 8th weeks of gestation. Genetic factors are believed to play a role, although a specific gene responsible has not been identified. Environmental influences and random chance may also contribute to this developmental anomaly. Unlike some other congenital heart defects, CTGA is not consistently associated with specific maternal exposures or syndromes. Now, let's get into the heart of the matter, the pathophysiology. In a normal heart, the aorta, carrying oxygen-rich blood to the body, arises from the left ventricle. The pulmonary artery, carrying oxygen, poor blood to the lungs, arises from the right ventricle. In CTGA, both the ventricles and the great arteries are transposed or switched. The aorta originates from the right ventricle, and the pulmonary artery originates from the left ventricle. But here's the corrected part. The atrioventricular valves, the tricuspid and mitral valves, are also switched. The tricuspid valve is connected to the left ventricle, and the mitral valve to the right ventricle. This creates two circuits, one where oxygen-poor blood flows from the body to the right atrium, to the right ventricle, then to the aorta and back to the body, and another where oxygen-rich blood flows from the lungs to the left atrium, to the left ventricle, then to the pulmonary artery and back to the lungs. So, while the arteries are switched, the blood still ends up in the correct circulation initially. However, this puts significant strain on the right ventricle, which is designed to pump blood to the low-pressure pulmonary circuit, but is now pumping to the high-pressure systemic circuit. This can lead to right ventricular failure over time. Additionally, many individuals with CTGA have other associated heart defects, such as ventricular septal defects of VSDs, pulmonary stenosis, or abnormalities of the tricuspid valve, which can further complicate the circulatory system. CTGA is a relatively rare condition. Estimates suggest that it affects less than 1% of all congenital heart defects. Because of its rarity and the often delayed onset of symptoms, precise epidemiological data can be challenging to obtain. Studies are ongoing to better understand the prevalence and geographic distribution of CTGA. The signs and symptoms of CTGA can vary greatly depending on the presence and severity of associated defects, as well as the age of the individual. Some individuals may be asymptomatic for many years, while others may experience symptoms in infancy or childhood. Common symptoms include cyanosis, or a bluish tint to the skin, lips, and nails, particularly during activity or crying, shortness of breath, fatigue and poor exercise tolerance, heart murmurs, which are abnormal sounds heard during a heart examination, and signs of heart failure, such as swelling in the legs, ankles, or abdomen. Infants may have difficulty feeding and may not gain weight appropriately. Diagnosing CTG typically involves a combination of methods. A physical examination may reveal a heart murmur or other abnormalities. An electrocardiogram or ECG measures the electrical activity of the heart and can identify irregular heart rhythms. An echocardiogram, or ultrasound of the heart, is the primary diagnostic tool. It provides detailed images of the heart's structure and function, allowing doctors to visualize the transposed arteries and any associated defects. Cardiac magnetic resonance imaging, or MRI, provides even more detailed images of the heart and blood vessels. Cardiac catheterization may be performed to measure pressures in the heart and blood vessels, and to assess the severity of any associated defects. Genetic testing may also be considered to rule out any underlying genetic syndromes. While CTGA itself isn't typically classified into distinct types, the severity of the condition and the types of associated heart defects can vary significantly. For example, a patient with CTGA and a large VSD will have a different clinical presentation and require different management than a patient with CTGA and only mild tricuspid valve regurgitation. The presence or absence of pulmonary stenosis also plays a crucial role in the clinical picture. Treatment and management of CTGA depend on the individual's specific anatomy and symptoms. Some individuals with mild symptoms may only require regular monitoring. However, most individuals with CTGA will eventually need surgical intervention. The specific type of surgery will depend on the associated defects. Options include repair of VSDs, relief of pulmonary stenosis, and in some cases, a double-switch operation. The double-switch operation involves rerouting the blood flow by switching the atria as well as the great arteries, so that the left ventricle pumps to the systemic circulation, and the right ventricle pumps to the pulmonary circulation. This can be a complex and high-risk procedure. Medications may be used to manage symptoms of heart failure, such as diuretics to reduce fluid buildup and ACE inhibitors to lower blood pressure. Regular follow-up with a cardiologist is essential to monitor heart function and detect any complications. Unfortunately, there's no known way to prevent CTGA, as it's a congenital heart defect that arises during fetal development and is not typically linked to modifiable risk factors. Women planning to become pregnant should ensure they are in optimal health, including managing any pre-existing medical conditions, avoiding smoking and excessive alcohol consumption, and discussing any medications they are taking with their doctor. Genetic counseling may be recommended for families with a history of congenital heart defects. The prognosis for individuals with CTGA has improved significantly over the past few decades due to advances in surgical techniques and medical management. However, long-term complications are still common. The most significant long-term risk is right ventricular failure. Because the right ventricle is pumping against systemic pressure, it is prone to eventually weakening. Other potential complications include arrhythmias, or irregular heart rhythms, tricuspid valve regurgitation, and sudden cardiac death. Recent research focuses on developing better methods for predicting and preventing right ventricular failure, as well as improving the long-term outcomes of surgical interventions. Researchers are also investigating the genetic basis of CTGA to identify potential targets for future therapies. The use of cardiac MRI is becoming increasingly important in monitoring right ventricular function and detecting early signs of deterioration. Continuous advancements are being made, striving to improve the quality of life and longevity for individuals living with this complex heart condition.